Good afternoon, everybody, and thank you all for joining us today for our NGA Center for Best Practices Public Health Leaders Call. We have a really good conversation planned for today. We'll be discussing public health governance. Just wanted to remind people to put your state next to your name in the Zoom box so we can help identify you as you ask questions and things of that nature. We cannot express our appreciation for you joining us today, and want to remind you that this call is completely informal. We are here to learn from you, to share with you, and just be of assistance in any way that we can. So now that I've gotten the housekeeping stuff out of the way, I'm Brittany Roy, and I serve as the Program Director for Public Health here at NGA. And with me today, I have Dr. Margaret Bourdeau. Dr. Bourdeau is a physician by training and now serves as the Research Director for Harvard Medical School's Program in Global Public Policy and Social Change. She has worked extensively with local, state, federal, and global health leaders to address health crises around the world over the last 25 years. The program's initiative, COVID Academy, connects a wide array of practitioners with policymakers to tackle the most difficult implementation challenges in the COVID response. Dr. Bourdeau and the Harvard team have been a big help to us and certainly a wealth of knowledge and experience that cannot be measured. So Dr. Bourdeau, I turn it over to you.
Thank you, Brittany. That was so sweet. Great introduction. Thanks, everyone, for joining us today. Indeed, this is our fourth COVID Academy facilitated call with the NGA. And as Brittany noted, COVID Academy is a Harvard Medical School program that seeks to connect really practitioners like yourselves with policymakers to consider how to overcome implementation challenges in COVID response. And of course, this is often meant focusing on the short-term emergencies and crises of the day. However, now that we are, realizing that these waves of COVID are looking like they're going to be with us for a while, we've really are turning our eyes toward the future. And this is this kind of sensitive period, as I've said before, where we need to take a moment and consider how we restructure, reconstitute, really re-envision the US public health enterprise. And state leaders are critical to that discussion. And these seminars really aim to engage all of you in discussion about your experiences with respect to public health system performance during COVID, and prepare state leadership to participate in the coming national conversation around public health system reform writ large. And today we're going to consider the problem of public health governance, and why, while I was preparing these slides this morning, my teenage daughter was preparing to go to school, and she kind of looked over my shoulder and said, "Oh, public health governance, what's that?" And I was like, well, any issue that has to do with who can or should or can't or is responsible for what and to whom, when it comes to public health and mitigating public health crises, is a governance question. And she sort of said, "Oh, well, that sounds really big. And well, good luck with that." And she kind of waltzed off to high school. And I thought, oh, she was echoing the trepidatious voice in my own head. And I was sort of reflecting on how every sort of crisis response I've been involved with, in the sort of after the acute period, there always seems to be this like ease with which we talk about things like data systems and even money and financing and workforce. And of course, those are what we've been discussing through our last three sessions. But really this leaving this question of sort of who does what, who's accountable to whom, seems very difficult even to find the words for. And of course, if you consider all of those other issues like data and workforce and finance without considering the governance questions, it's a bit like putting bricks in a yard hoping that a house will materialize. So, today we're going to tackle this issue head on. bravely look at it in the face and really ask ourselves, what is the role of state leaders when it comes to managing public health and health crises now? And what could their role be in crafting public health governance reform so we have a coherent public health system that can handle a 50-state emergency like COVID now and in the future. I am enormously comforted by and honored to be joined by three really spectacular discussants. Professor Wendy Parmet is the George J. and Kathleen Waters Matthews Distinguished Professor of Law and Professor of Public Policy and Urban Affairs at Northeastern University, where she is the Faculty Director of the Center on Health Policy and Law. Professor Parmet will start us off with the legal perspective on public health governance, namely how legal structures underpin key governance issues, who has the authorities based on which laws and statutes to do what. Professor Parmet will also touch on the legal challenges that have arisen over the course of the pandemic, seeking to curtail public health powers. We will then turn to Dr. Anand Parekh, who is the Chief Medical Advisor at the Bipartisan Policy Center since 2015, where he has provided clinical and public health leadership. And Dr. Parekh will present the findings of the Bipartisan Policy Center's recent report, Public Health Forward. Now, this report presented considerations and a framework for state leaders to both clarify governance roles and responsibilities and communicate these to both stakeholders within the public health system and the public at large. And then finally, we will turn to the Deputy Secretary for Prevention, Safety, and Health at the Washington State Department of Health, Ms. Lacey Fehrenbach. Among her many jobs, she oversees the strategic and operational activities of the agency's COVID-19 response. And Dr. Fehrenbach will discuss Washington's experience governing through the COVID pandemic to date and help us reflect on issues like state versus local public health authorities, governor's emergency powers in the context of a protracted health crisis, and what folks in Washington state are thinking about for the future. Each of our presenters will present for about 10 to 15 minutes or 5 to 15 minutes each, and then we will open it up for discussion. While they are presenting, if you have questions that you'd like to queue up in the chat, that would be most appreciated. And then we'll break for discussion. So just to go through kind of quickly the ground rules of this seminar, as you logged on, you probably noticed that you were being recorded. It is true that the background and presentations are public facing. They're recorded and we hope to post them on our website. However, following the presentations, we will turn off the video. We'll turn off the recording. And that really is a chance for us to have an internal NGA members only discussion, as I like to say, just us chickens. And that really is a chance to, ask questions that you feel uncomfortable asking, share, concerns, anxieties, etc. So we have a little bit of time in our day to, really tackle hard things together. And then just to say that that portion of the discussion is really that discussion portion, the non-recorded portion is really Chatham House rules. So we ask that, you can mention to others themes you've discussed, but really what we talk about is not for attribution. In the following weeks, we will also put together a summary brief that summarizes the presentations and the themes of each session, and those will also be available on our website. So those are the ground rules. I think the sort of with my daughter's voice echoing in my head about how to kind of get our arms around this issue, before I turn it over to Professor Parmet, I just want to give folks a three quick points that I think sort of help us, oh, there's my dog, help us sort of grab hold of this discussion and keep ourselves grounded. and also recognize some of the challenges in this with respect to this theme. So the first is that states have very different vertical organizations of their health systems. And what I mean by that is that there are different relationships between the state level and the local public health agencies, if there are any. And so just to share with you a quick map that I pulled from ASTHO's website. So this is ASTHO's sort of governance classification of the vertical organization of states. And they sort of group states according to 4 categories. The first is states that organize their public health enterprise very centrally. This is where local health units are primarily led by employees of the state and where the state retains authority over most fiscal decisions. The second, sort of on the other side of the spectrum, is the states that are decentralized or largely decentralized. This is sometimes referred to as having home rule. And this is where local health units are primarily led by employees of local governments, and local governments retain decision-making and fiscal authority. And then there's sort of 2 intermediate models. One is a shared model where local units may combine both state employees and local employees, and the decision-making processes is also divided between states and locals. And then there's mixed, where you have some jurisdictions that are locally controlled and locally run, and there are some jurisdictions that are state run and controlled. And so you can imagine how that matters, right? With respect to some of the other issues we've tackled. If you're going to tackle the project of building out your state's public health workforce, that's going to look different depending on how your state is vertically organized its public health enterprise, right? Same can be said with data systems, same can be said with financing. So that's sort of the first point. The second is that also there's a variation with respect to how states sort of horizontally organize their public health agencies across state government. And I sort of mean this in 2 respects. And this is my own nomenclature, so you heard it here first. But what I mean by that is that where the different parts of the public health enterprise sit within the state government matrix differs. So, a public health department might sit alone, or it might sit under a larger health and human services type agency at the state level. And then, where does the public health laboratories or laboratory sit with respect to those entities as well? And then the second consideration is how does the public health sort of agency and operations interface with the healthcare or medical care or direct patient care programs like Medicaid, for example. And that will also have impacts with respect to who does what, who's responsible for what. If you have a public health agency that does direct patient care, you're going to be able to push some of your responsibilities through your public health agencies versus, through your healthcare delivery and medical care agencies. So I think the basic point there is that what we've sort of seen throughout COVID is that it's actually pretty easy to lose track of exactly who's doing what at the state level. And, with a crisis like COVID, all of a sudden there was, wait, who's responsible for that? How do I operate the levers here of the sort of state level public health enterprise? And I think one manifestation of this, was the need for the National Governors Association to essentially set up a legal counsel office for states that had little in-house public health law capacity. So we'll talk about that a little bit more, but that was sort of fits under that rubric of like, how are things organized horizontally at the state? And then the last point that I'll just mention is that, it's very tempting when considering these first 2 points to think, every state just needs to work it out for themselves, just clean their own house. This is going to be something that Idaho's going to fix, and Louisiana, New Jersey, et cetera. However, we really do need to keep in mind that, of course, what happens in Vegas doesn't stay in Vegas. What happens in Nevada doesn't stay in Nevada. The implications of how one state organizes its public health governance has implications for all the states around it, for the country as a whole, and of course, for the whole world. Because, hey, this is an infectious disease that we're dealing with that can cross borders because people cross borders, right? And animals cross borders, as we've seen COVID, spread throughout animal populations as well. So, I just was reflecting on this issue when I remember early in the pandemic, there's a lot of news stories about how Sweden was going to be very permissive in its laws and policies of how it was going to handle COVID. And I remember thinking at the time, I was like, Sweden is making that decision for the entire world. That, that is something that is going to have impacts for all of us. And we really have to get out of our traditional and perhaps inappropriately comforting sort of idea that this is something that can be handled state by state. So those three themes, how states organize vertically, horizontally, and the implications for all of us, I think are themes that you'll sort of hear about throughout each of these presentations. All right, so enough said, over to you, Professor Parmet.
Thank you so much. Sorry, it's a little dark here. Let me just share my slides. And are they visible?
You're good.
I hope it works. I'm having all kinds of not good computer problems today. So apologies for that. And give me one more second to figure out where I'm at right now. Okay, so I am going to try to give a very bird's eye overview of some of the key legal issues that relate to public health powers and emergency powers in particular. I'm going to give a little bit of history, talk some about what has happened in the last 2 years, and then share some thoughts about moving forward. I should say at the beginning, I'm going to mention, I hope at the end, if I have time, some work I've done with the Uniform Law Commission. I'm speaking on my own behalf. Nothing I say should be attributed to the commission. And let's see if my computer will let me. Sorry, guys, I'm just okay. So public health powers at the state level really date back to prior to the Constitution and the colonial period. And when epidemics struck, as they did constantly, it was pretty common for cities, for towns, and for colonies, and then the states to delegate very broad authority to some official or group. Committees would be formed, basically to do what is necessary to solve the problem. Very broad grants of authority. These grants were usually at this period ad hoc, and they existed alongside more specific public health laws, for example, laws regarding quarantine, which go all the way back to the colonial period. In 1799, the state of Massachusetts actually authorized, established the first standing public health commission that was in Boston, and my picture here is Paul Revere, who was the first health officer appointed. In 1866, New York established the Metropolitan Board of Health and gave it very broad authority. And throughout the 19th and 20th centuries, more and more states began to create health departments and give them very broad authority to do what needs to be done, right, in their minds, to prevent diseases, often in particular communicable diseases. These grants of authority, again, coexisted alongside disease-specific laws and sort of measure-specific laws. So, for example, we have a lot of tuberculosis control laws. And it's always been an interesting challenge to understand how these disease-specific laws sort of coexist with these very broad, do what you need to do sets of laws. during the Cold War, two things happened, a trend, obviously not in every state. First of all, more states centralized. Margaret was just talking about the differences, but actually more states, we saw a trend in the 20th century to centralize public health authority at the state level. And also states enacted what we tend to call general emergency powers laws or civil defense laws. These are the laws that are commonly used. Governor can declare an emergency and do all kinds of things, in the event usually of a natural disaster. These laws proved to be really important during COVID. Now, traditionally, courts throughout the country, state and federal courts, have read these very broad delegations of authority to health departments and health officials at both the state and the local level very broadly. And I quote here on the slide, I'm not going to restate it because of time, a quote from Justice Harlan in the Supreme Court in Jacobson versus Massachusetts, a 1905 case. This case had to do with a due process clause challenge to Cambridge, Massachusetts vaccine mandate, but the mandate was imposed by the Cambridge Board of Health pursuant to a delegation from the state of Massachusetts. And you can see the language here, which is really very common for the period and even from the earlier period, right? The idea that, governments need to vest authority somewhere and somebody's got to figure out what to do when there's a problem. And it should be, people because of their fitness. Today we would say expertise. They should be the ones to do it. And the court thought that that was just the way it is, right? And that's the way it had been for a long time. In 2001, following the 9/11 terrorist attacks, as well as the anthrax attacks on the US mail, the Centers for Disease Control and Prevention asked Professor Larry Gostin of Georgetown Law Center and Johns Hopkins and his colleagues to draft a model public health emergencies law. This act was drafted around the same time that other efforts were going on. Often Professor Gostin was involved in most of these efforts to update, modernize, and codify public health law generally. And there really were two concerns behind this process. One was that there was this sort of confusion about the general laws and the specific laws. Again, how did they reconcile? And two, that the Supreme Court in the 20th century had conducted what is often called the due process revolution, clarifying that people have rights, right, before they're, and so there are all these old laws and things, people would be quarantined, their property would be taken, they would be locked up, they would be forced to be treated. All kinds of things went on in the day, and there should be some protections and some legal protections. So this law attempted to do this, the Model State Emergency Health Powers Act. It defined a public health emergency, it gave the governor authority to do it, and then it lists a whole bunch of different powers that the governor would have upon the declaration of an emergency. It provides some level of due process protections. We could argue about whether they were adequate or not. And it was extremely influential. Many states adopted parts of the Model State Emergency Powers Act, but not every state. Okay, that's sort of where we were in the, winter of 2020. Starting in March 2020, when COVID really became present in the United States, or at least visible, governors and mayors imposed a range of community mitigation measures to slow the transmission, to flatten the curve. That was a term that was used a lot then. These included shutdown orders, closing businesses, imposing capacity limits, limits on medical procedures, for example, postponing elective surgeries. Later, we got masks and then vaccine mandates. what's really interesting to understand is that the Model State Emergency Public Health Act and really none of the state laws specified these particular procedures for public health in the way that they were used. And what executive officials at the state and local level did throughout the country was rely on their general powers, either their general public health powers, those laws that go back to Paul Revere, or their civil defense powers, right? So there were, and these statutes are very broad, and they seem to give a lot of authority once an emergency was declared. But they don't specifically authorize mask mandates. They don't specifically say, right, you can limit the capacity of people attending restaurants, right? The kinds of measures that were seen as really important and were imposed to varying degrees nationwide in the early days of the pandemic just aren't specified. Okay, so early on, back again, spring of 2020, the courts almost consistently upheld all the challenges that were brought to all of these various laws. The challenges were brought on a bunch of different grounds. If I named every kind of challenge, it would take the rest of our hour, so I won't, but we could divide it to say individual rights grounds and sort of structure, scope of authority grounds, and mixed in with there was administrative procedures issues. Initially, most courts upheld most orders. They cited Jacobson, where in an emergency a governor or mayor can do what governors or mayors think they need to do. That was sort of a quick approach to it. The Supreme Court in May of 2020, by a 5-4 vote, rejected a challenge to a state law that regulated worship. And the Chief Justice cites Jacobson and says that the Constitution principally entrusts health decisions to politically accountable officials. That judicial deference to the exercise of emergency powers really begins to change dramatically in the fall of 2020, although there were some earlier cases, which I'll get to in a moment. The Supreme Court first begins to change its approach to free exercise cases, and I won't go all through the free exercise analysis, although we can in questions, but the court didn't only move to saying that states could not regulate worship sort of directly, but also would have trouble imposing other laws if they affected an activity that somebody believes burdens their religion, right? So limits on the number of people who could gather in homes. The court said in Tandem versus Newsom, violates the free exercise clause if people want to gather in homes to do Bible study. And presumably that applies to a lot of other things, right? Another court, a lower court said, for example, you can't close religious, you can't apply closing of all schools to religious schools, okay? So sort of a opt-out for religious activity or what affects someone's. Then the other trend to note is that beginning with in the spring of 2020, in a case called Wisconsin versus Palm, we began to see some state courts reading these general emergency powers narrowly. And they did it, what I would say is in the shadow of delegation, suggesting that the governor's readings of their emergency powers as authorizing all of these kinds of orders that we've talked about would be unconstitutional. If the statute gave that much power to the governor, it would be an unconstitutional delegation of legislative authority. So it must be that the statute can't. And what's interesting about these cases is they kind of, they're not doing textualism. They're reading these general grants kind of as if they have, except you can't do all these different things. The Supreme Court adopted that approach last summer when it held that CDC, now this is looking at federal law, could not have an eviction moratorium. In the Alabama Association of Realtors case, the CDC invoked what it called the major questions doctrine, which is the court says when an issue has a significant effect, don't know what that means, on the economy or political, if it has a major impact on the economy or the country, it's a big issue, big deal. You can't use a general grant of authority. It has to be specified. And the Supreme Court used that same reasoning this past January in saying that OSHA could not have a vaccine mandate. Again, although OSHA has general authority in an emergency issue, there's nothing in the statute that says, and you can have a vaccine mandate. So what we've seen, and we see this in several other state courts, is this change of reading authority, which is actually really important to understand, what authority you've got in your state. You may have a statute that seems to say you can do whatever is necessary to protect the public from a communicable disease. It may be you can't do that anymore. It also means that the fact that the statute says you can do A, B, and C, quarantine, fumigation, mandatory medical exams, is going to be read to say, therefore, you can't do anything else, no mask mandates, right? So we're seeing just this flip in how courts interpret these statutes. We're also seeing, I'm going to rush through a lot of state legislation. You folks probably know this more than I. I'm involved in a group called Act for Public Health. I don't speak for them, but they've been tracking, and I do recommend, if this works, maybe it does, maybe it doesn't, maybe I shouldn't try this. It's not going to work on this screen, so I'm sorry. But maybe when I'm done, I'll put it in the chat, bill tracking on these changes. But we're seeing a lot of state legislatures are moving to restrict authority, both for the governor, health department, and local cities. Okay. Sorry, folks. Again, computer troubles. Let me see if I can go back. I think I slipped a slide. Okay, so moving forward, last point I want to make. It seems clear to me that legislative reform is essential. Our statutes did not contemplate the type of measures that were needed. And these general catch-all phrases, you can do whatever you need to do, courts are increasingly unwilling to go along with that. To respond effectively to the next pandemic, we really do need statutory revisions that clarify the powers of the governor, the health officials, the independent health boards, and municipal authorities and county authorities, and provide clearer metrics, or what some of us have been calling guardrails, to prevent abuse. The kinds of due process protections that were put into the Model State Emergency Health Powers Act are really about individuals, being quarantined. They're not about community-wide measures. So we need to rethink some of this. And we also need to rethink some of the administrative law and procedural law issues that have been the cause of a lot of litigation. I could talk more about that. The drafters of these new laws need to understand that we do not know either the epidemiology or the politics of the next pandemic. Some states are, for example, saying, well, health boards can't close schools. But they're thinking, well, COVID doesn't affect kids. But you know what? The next pandemic could hit kids and not seniors, right? We just don't know that, right? We really need to reform our laws behind sort of a veil of ignorance. We just don't know what the politics is going to be. Maybe next time Republicans want the stricter laws, and that has happened at times in our history. And Democrats are the ones for the looser laws, think Ebola or HIV/AIDS. So we need to sort of not make assumptions about the political valence, and we not make assumptions about the nature of the epidemiology. 2 years ago, the Uniform Law Commission established a study committee to decide if a uniform or model law should be drafted. I had the privilege of being a reporter on that. For that committee, it concluded, for many of the reasons I've already said, that we really do need a new law, and that they could draft a model by nonpartisan law that would seek to clarify powers, but also clarify metrics and guardrails, and assure compliance with the rule of law. So a new committee has been formed. Rab Gattner from St. Louis University is the reporter, working on the draft of that. I am very hopeful that this committee will provide a strong model law. But even if it doesn't, I think the task remains urgent as we think about governance. We can see where our laws fell short. We can see where our courts had problems. We know, I think, that this nation did not do as well with COVID as it could have, would have, should have done, to tragic effect. Law and governance is important. And hopefully this is a moment where we can now learn from past mistakes and move forward. So thanks.
Thank you so much, Professor Parmet. That's wonderful. I'm going to quickly turn it over to you, Dr. Parekh. And for some reason, I'm having a problem in my chat where I can't seem to type there. So my computer's having a little bit of a nervous breakdown, but I would like to encourage all of you to, as you're listening, to go ahead and put questions in the chat that we can turn to during our discussion.
Great. Dr. Bordeaux, thank you so much for that introduction. Great to be with all of you. Thanks to the NGA, as well as Harvard Medical School, and Professor Parmet for that presentation. I will try to be brief here. I'd like to provide just a little bit of context of some work that has been underway over the last several months, led by the Bipartisan Policy Center in Washington, D.C., as well as then just offer a couple of comments on public health governance. As Margaret mentioned, we are a nonprofit organization in Washington, D.C. that tries to take the best ideas from both political parties to promote health security and opportunity. Last year, we were approached by 9 national public health associations, as well as philanthropies, to help articulate a 5-year vision for governmental public health in the United States, and to develop an actionable framework for state and local elected and health officials to reach this vision. Obviously, public health has been at the center of COVID-19, and I think many of us felt that there's a moment here, a moment to sort of redefine public health, if you will, and make sure there's a consensus in this country about public health, its importance, as well as its role. This effort focuses at the state and local level. So again, the federal government has a critical role vis-a-vis public health, but this effort was focused at the state and local level specifically. This effort also came at an important time. Lots of money through COVID relief packages coming to states to tackle the COVID-19 pandemic, providing public health really an opportunity. Again, this is short-term dollars, not the long-term sustainable investments that public health needs in this country, but still an opportunity to ensure that dollars are spent efficiently to help the public and save as many lives as possible. And I think the initiative also, of course, comes at a time, I don't need to tell anyone here, but at a challenging point for governmental public health in this country, given the politicization of public health that we've seen during the pandemic. We at the Bipartisan Policy Center do what we normally do and established a bipartisan task force of former and current elected officials, governors, mayors, county commissioners, state legislators, members of faith-based community, business sector, healthcare community. As you see, former Governor John Kasich from Ohio participated, as did former Governor Mike Beebe from Arkansas. And essentially what this group came up with, and it wasn't just this task force. I think it's important to know there was a national leadership group made up of public health officials. We had town halls, we had focus groups, we had requests for information. We had roundtables of experts on many different topics. It was really a 6-month effort. Wanted to make sure this wasn't a top-down effort, but really sort of bottom-up, or everyone had an opportunity to contribute. We worked with NGA as well as many other organizations as well to ensure both health officials and elected officials were able to provide input. But ultimately, what the bipartisan task force came up with is that in 2026, in a 5-year vision, that our country becomes healthier because elected and public health officials seize the historic opportunity to invest in new and transformative ways to modernize our system. And that involves advancing health equity, ensuring there's sufficient predictable and flexible public health funding, ensuring there's a robust, modern, interoperable, secure public health information system. Today's topic, obviously, ensuring that there are modernized laws, policies, and statutes to protect and promote public health, and then ensuring that there's a highly skilled, trained, and diverse public health workforce. And another way to really depict this is, again, with the overarching goal to ensure all Americans have the opportunity to attain their highest state of health, a 5-year plan that has these 6 really areas: financing, laws and governance, community engagement, partnerships, workforce, data and information technology at its core. And so the task force spent quite a bit of time looking at these 6 areas, and ultimately what they ended up doing was identifying 2 actions in each of these 6 areas. So a total of 12 actions that both elected officials at the state and local level, as well as 12 actions at the state, 12 actions for both health officials as well as elected officials, realizing that some of the actions were going to be different. What an elected official can and can't do is different than what a health official can and can't do. So 2 sets of actions, both for health officials and elected officials. And I want to just take maybe just a couple of minutes and at a high level talk through the laws and governance section. So I think the overarching finding of the task force, and I think this is very similar, Dr. Bourdeau talked about this with our sort of vertical organization concept. I think they were very struck by the fact that there is so much variation in public health authority between the state and local level. And we heard about many states having a centralized or a mostly centralized system where the state maintains authority over local public health operations. Many states have a decentralized or mostly decentralized system. For other states, it's mixed. And obviously governance variation resulted in differing policies, interventions, messaging across states and local jurisdictions. And as was already discussed, likely the public at times interpreted this as public health operating outside its scope of authority without realizing that there is, in fact, so much variation. So I think that was the overarching takeaway from this task force, really just a striking variation in public health authority. They really came down and to consensus with 2 actions. The first, to review and evaluate modernized public health governance structures and statutory responsibilities. This really echoes Professor Permet's presentation that public health is really embedded in the law. It's not something sort of public health folks doing whatever it is that they want to do. There are some statutory roles and responsibilities that need to be met, and public health is really grounded in that law. And I think the task force really appreciated that, specifically in terms of this review and evaluation, modernizing of structures at the state level. Our task force felt that it's important that governor advisors, number one, determine the proper state local framework for preemption, establishing minimum and maximum requirements. So we saw preemption play out quite a lot in states during this pandemic. Number 2, consider how structures, processes, roles, and responsibilities should remain the same or change during a public health emergency. So should things be differently? Should things be done differently if there's an emergency versus if not? Number 3, examine whether existing funding streams are sufficient to support the revised public health governance structures. And then number 4, ensure that that there are opportunities for the public to provide input in any rulemaking process, and to ensure that it's widely publicized, transparent, and easily accessible. We often forget that term public health is made up of 2 words. We spend a lot of time on that second word, health, but certainly that first word, public, absolutely critical to understand where the public is, to meet them where they are, and ensure that they have a say and a role in terms of maximizing health in the community. And so I think the task force felt strongly that every state ought to be going through action 1 in some form or fashion. They elevated Indiana as a really nice example. The governor there recently has established a 15-member public health commission examining the state's preparedness for health emergencies, funding plans, governance models at the state and local levels, and data collection measures. This is being led by former state elected officials as well as health officials, bipartisan in nature, not going in saying, how do we curtail the powers of public health? How do we break up public health? But how do we more broadly promote the health of our constituents? So a very empowering way to strengthen public health. And many states are thinking about variations of this, but that's just sort of one example. And then the second action the task force landed on was to support and clearly communicate the roles of public health departments to the public. And this really gets at this idea that health officials and elected officials, they have to always be working together, and they have to be on the same page, that particularly in an emergency, we can't afford sort of mixed messages. And so specifically, the task force called that coordinating messages in the governor's office with public health departments during emergency and non-emergency situations, engaging with constituents during public health emergencies to correct misinformation and explain the role of public health departments. There really ought not to be any venue where the health official is out on their own without their counterpart at the local level or the state level, talking about the role of public health during an emergency and protecting the public in a public forum. And so that's why sort of communication was sort of elevated to a second critical action that state and local elected officials should really focus on. Certainly at the public health department level, ensuring that public health departments and officials have counsel so that there's an appreciation of public health law, also very critical as well. So those are just, I think, to echo what you've already heard, a couple of the high level actions. And you can find in our report, which I'll put in the chat in a moment, some very concise actions at the state level, at the level of the governor, in terms of how governance and looking at public health laws could be advanced moving forward. And I think as a next step, again, trying to understand where your state is and seeing how some of these recommendations can then apply. Every state's going to be in a little bit of a different spot, but I think you're beginning to see a little bit of a common theme there. So with that, I will maybe pass it along to our next presenter.
Fantastic. Thank you so much. I am going to quickly hand the mic over to Ms. Fehrenbach. I think we are coming up on time, and so I just was going to say that I know Brittany has a hard stop at 4, but the party shall continue. So we hope that folks can stick around a little bit, certainly after the presentation, and we will have a kind of water cooler discussion for those of you who can join us. Over to you.
All right, can you hear me? All right, excellent. Honored to be here and happy to stay a little long and answer questions and follow up if there are any. I am very honored to be with this esteemed panel and had the privilege of leading the COVID response in our state from a public health perspective, so coordinating the activities internally within the Department of Health, and then working with our local and tribal partners, sister state agencies, and the governor's office on our statewide approach. So pleased to share our experience from a governance perspective and a little bit of a preview of where we're going. And just want to thank the Bipartisan Policy Center for the report. We find it very helpful to guide our actions going forward. I'm in one of those home rule states that you saw Dr. Bordeaux put up earlier in the presentation. So Washington State has 35 local health jurisdictions. We have 39 counties. There are 3 counties that have multi-jurisdiction health departments, and each of those health departments has a local health officer, and the majority of the powers and duties to control communicable disease in Washington State exist at the local level in our state. So This is sort of the map, and underneath are the populations in those jurisdictions. So you can see Seattle-King County, our largest jurisdiction, 2.3 million nearly, and then some fairly small jurisdictions with a few thousand people. We also have 29 federally recognized tribes in Washington state. These are sovereign nations, and they are part of our public health system. So they have the ability to set their own policies and laws. And we work with them in a government to government way. And I'll share a little bit more about that in a few moments. So when we're looking at our general public health system within the state of Washington, we have local public health, as I mentioned, our sovereign tribal nations and urban Indian health programs. And then at the state level, there are two entities. There's the State Department of Health, where I work, and to the earlier point of what that includes, we do have our public health lab. We do have a number of programs like communicable disease prevention, maternal child health, chronic disease prevention, as well as the public, I think I mentioned this, the public health lab. We are the entity that licenses healthcare providers and facilities for the most part, but we're not. There's a separate agency for the Medicaid program. That's the Healthcare Authority in Washington state. Our Department of Social and Health Services has a number of facilities, health facilities, primarily behavioral or developmental disability facilities that they run. So we worked very closely with them on care issues for their populations. And then we also have a state employee safety agency called the Department of Labor and Industries that was important and involved in our public health response. They do worker protections in Washington state. So, examples from the COVID-19 experience, the State Board of Health is the rulemaking body. So that's the other part on the state side. We worked very closely with them, but an example would be in COVID, they have the notifiable conditions law in our state, and we had to do emergency rulemaking through the board. So the Board of Health had to pass rules around what is required from a disease reporting perspective related to COVID-19. At the secretary's level, we do have some ability to control communicable disease. Generally, that comes through the secretary's powers and duties, which include the ability to sort of step into the shoes of local public health in some limited circumstances. And that includes if a local health officer fails to do so, when there is an emergency where the safety of the public health demands it, or by agreement of the local health officer or board of health. So a local could ask the secretary to step in and act on their behalf. And an example of an order that the secretary issued is around face coverings in Washington state. And they're using the emergency power. I will also say this was alluded to earlier. It's very hard to do these policies state by state or have differing practices state by state. The same thing is true when you go county by county. Many instances of people who live in one county and work in another, or live in one county and go to school to another. In another, we have some school districts, not many, but a handful that actually cross county borders in Washington state. So, the experience here was that pretty quickly, we did start, as we would with local control. We chose in many cases to take a statewide approach because it is hard to have differing policies that impact the same population or very similar populations differently. The thing that you don't see here is the governor's emergency powers, but they were used. They are still used in Washington state, and the governor does have powers around closing schools, businesses, setting limits on occupancy or requirements that must be in place. So I mentioned the Secretary's face covering order. You know, the governor, as part of some of the reopening plans, put in requirements that helped businesses, ensure adherence by setting the expectation that businesses enforce the face covering order among their employees and among their customers. So that's an example. We also had, you know, like a handful of other states phased reopening that allowed different occupancy levels at different levels of disease. And that was governed through the proclamation. The other thing that the governor can do is waive administrative requirements related to the emergency. You know, so that's an example. We have waivers in place that have allowed retired healthcare workers to come back more easily, allowed us to accept volunteer healthcare workers from other states. And those waivers still are in place, even though, you know, nearly all of the other statewide requirements have gone away in terms of economic restrictions, recreation restrictions, and statewide indoor mask requirements with some pretty limited expectations. I will say, you know, because this is a home rule state, we tried to always work very closely with the governor's office and our attorney general, who provides legal counsel to the Department of Health and other state agencies, in addition to the other roles an AG's office will play, to write our policies in a way that they were a floor. And if a local jurisdiction chose to implement additional measures or be more protective, they could. So an example there, you know, there was a period of time in the summer of last year when the state relaxed its indoor mask requirement for people who were fully vaccinated. And as the Delta wave surged in Washington state, there were some local jurisdictions that put in universal indoor mask requirements in place ahead of the state. The state, again, ultimately put in that expectation in mid-August. Another example, there was a statewide requirement for proof of vaccination for large events. And then there were a few, so only for large events, in terms of, you know, the public and recreational activities. There were, I believe, 3 counties that put in a requirement, you know, also to go to a restaurant or bar, you had to show proof of vaccination. So an example there of creating that flexibility at the local level. I mentioned the really strong partnership with our Attorney General's office on understanding what the authorizing environment is and isn't, and what the limitations are. I think the other one is having, you know, really good continuous communication with your governor's office, or between your governor's office and your public health department. We talked regularly with the governor's health policy advisor, as well as some of the other advisors, education, recreation, external affairs, you know, really making sure that we're finding the right balance between what we're trying to achieve from a public health perspective in terms of limiting transmission or encouraging and promote vaccination, but also making it something that can be implementable on the ground and can, you know, be worked through from a policy perspective. So lots of extensive communication with them and engagement with stakeholders out in those sectors and in the public and at the local level. So what are we thinking about going on beyond COVID? You know, the first is we don't think we're past COVID quite yet. We're in Washington State really building a plan to coexist with COVID. And that includes, you know, sort of preparing the public for what may come and encouraging a journey of recovery and resiliency, but being ready. And we have issued a plan through 2022 of the things we'll be doing and the commitments we have made as a state to maintain capacity to deal with future waves or surges should we see them. You know, and also we do think we are on a good path based on the level of vaccination and infection-acquired immunity, and all of the tools we have at our disposal at this point with therapeutics, antivirals, monoclonals, as well as, pretty widely available testing capacity. We are a state that had been working on public health modernization before the pandemic. And during the pandemic, we did sort of adjust our kind of where we were going there, but also I think the pandemic really did shed a light on some of the points Dr. Parekh made, that you do need a level of investment and some level of flexible funding. And I'll show a slide around where we are with investment. We have been engaged with a number of other states and in Washington State with our local tribal partners and the State Board of Health on mapping out a strategy for what the foundational areas are. Those are listed up above for our state at the state, local, and tribal level, and then what the capabilities are and how we will pay for that through a combination of federal and state investments. There were some policies that passed, not in this current legislative session, but last year that brought a higher level of visibility and attention to foundational public health services. And that, I have the bill cited there. It includes a couple of other provisions, but two really key things. It establishes an advisory board at the state level that is really charged with providing feedback on the governmental public health system and making formal recommendations to public health, to monitoring our performance as a system, developing goals and direction for the future of the system. They advise and report to the Secretary of Health, and they coordinate with the Governor's Office, the State Board of Health, local health, and the Secretary. They evaluate emergency response and provide recommendations for future responses, and they evaluate the use of foundational public health service dollars. So that was one board that was established, and it actually just very recently formed here weeks ago, I think. And then there was another provision that sort of articulated expectations for types of professionals that need to be on a local board of health, and essentially says that you need to have public health professionals, consumer representatives, and community stakeholders on your board of health, in addition to local elected leaders. Or there's an option to have a local community health advisory board. There was an investment made in establishing some level of regional capacity at the state Department of Health level, so that we can bolster the system, state, local, tribal, in Washington State. We have been on a journey also around modernizing our data systems to think about pulling together different types of data, including healthcare, public health, social service data. And I think there may have been a presentation from our group to this group previously on some of that. That's a long-term investment that our state is making and includes many agencies beyond just the Department of Health and our data. And then I think the other piece that we have committed to from our experience in the pandemic is a very deep focus on addressing the root causes of inequities in health outcomes, social and environmental determinants of health like poverty, housing, racism, climate, and so on, and doing that with our sister agencies, local and tribal partners. This is a summary slide of the work that we have been doing to fund foundational public health services in Washington State. There is a steering committee of state, local, tribal health leaders, as well as the State Board of Health, that did an assessment of what we had and what we thought we would need to meet those foundational capabilities and foundational programs. And we started out back in 2016 with a $450 million estimated gap this is per biennia. And there were some investments made in the two biennia prior to the pandemic, which happened in the middle of that 2019-2021 biennium. And you can see how that the impact of the pandemic, I think, changed the attention to public health and the investment in public health. We did get, some additions to the 2021-2023 biennium that we're currently in because of the pandemic, and then we're not quite fully wrapped up with the next budget, but I put in the placeholder number for the moment of $324 million, so that gap has become much smaller. These are investments this is not only for the State Department of Health, but also for the locals and tribes. And that steering committee that put together the asks also has them mapped to those capabilities and programs, and helps guide where they go. And then that advisory board will be monitoring and making future recommendations. That advisory board includes elected leaders, it includes the governor's office, it includes a whole host of public health partners and stakeholders in Washington State. So very excited and humbled by the work ahead of us to really move this vision forward and serve the people of Washington better. I am going to close really quickly here with a little more on communication. In addition to being in constant communication with the governor's office, we tried to be very visible to the public and accountable to the public and the media. Very frequent media briefings with Department of Health, sometimes also with the governor. And then we had a pretty active social media and paid media campaign that aligned on our messages and where we were as a state, to keep people informed. On the visual media side, we engaged as many trusted or respected leaders as we could to amplify our messages, including, local healthcare providers, local community leaders, religious leaders. We have even some Washingtonians who would volunteer to tell their story in a short ad. And then, of course, local celebrities here in Washington State, all of the major sports teams engaged in our vaccination campaign. So the Seahawks, the Reign, the Sounders, the Mariners, the Kraken. And I can get the link and people can see some of the videos that have aired here. We had Stone Gossard, who is a member of Pearl Jam, who helped us promote our exposure notification program. And then we also have, all types of providers, including naturopaths that helped us get messages out about vaccines and dispel misinformation about COVID or vaccines or both, as well as what to do when you test, when to test, what to do if you test positive, how to have a safer gathering, when to wear masks, et cetera. And then I think the other part that's not as visible to everyone as all of those ads, engaging in trusted messengers at the community level that are doing more on the ground direct communication. So that also religious leaders, community-based leaders, local libraries and others that would host vaccination events or test sites, talk to their communities, foster trust, dispel disinformation, and we are really looking forward to continuing some of those partnerships going forward. We have a vaccine implementation collaborative that includes hundreds of local community leaders that really helped us get messages out in a way that was acceptable in their community. And there's just huge opportunity to think about other types of health issues we could tackle with that group. We also engaged extensively with the private sector here, and they were key on a lot of our projects, including some of our data projects, as well as our testing and vaccine efforts. So with that, I will turn it back over for questions if there are any.